Welcome to this lecture for MBBS students on stable angina. Please hit the subscribe button if you have not yet subscribed to the channel. Coronary heart disease, CHD, is the most common form of heart disease and the single most important cause of premature death in Europe, the Baltic states, Russia, North and South America, Australia and New Zealand. By 2020 it is estimated that it will be the major cause of death in all regions of the world. 1 in 3 men and 1 in 4 women die from CHD, and millions of people have angina. Disease of the coronary arteries is almost always due to atheroma and its complications, particularly thrombosis. Stable angina. Angina pectoris is the symptom complex caused by transient myocardial ischemia and constitutes a clinical syndrome rather than a disease. It may occur whenever there is an imbalance between myocardial oxygen supply and demand. Coronary atheroma is the most common cause of angina, although the symptom may rarely be a manifestation of other forms of heart disease, particularly aortic valve disease and hypertrophic cardiomyopathy. Clinical features. The history is by far the most important factor in making the diagnosis. Stable angina is characterized by central chest pain, discomfort or breathlessness that is precipitated by exertion or other forms of stress, and is promptly relieved by rest. Some patients find that the discomfort comes when they start walking, and that later it does not return despite greater effort. Warm-up angina. Physical examination is frequently normal but should include a careful search for evidence of the following: aortic valve disease, hypertension, diabetes mellitus, left ventricular dysfunction, cardiomegaly, S3, arterial disease, carotid brute, peripheral vascular disease, anemia, thyrotoxicosis, metabolic syndrome, central obesity, acanthosis nigricans, skin tags. Investigations. Resting ECG. The ECG may show evidence of previous MI but is often normal, even in patients with severe coronary artery disease. Occasionally, there is T-wave flattening or inversion in some leads, providing non-specific evidence of myocardial ischemia or damage. The most convincing ECG evidence of myocardial ischemia is the demonstration of reversible ST segment depression or elevation, with or without T-wave inversion, at the time the patient is experiencing symptoms, which may be spontaneous or induced by exercise testing. Exercise ECG. An exercise tolerance test, ET, is usually performed using a standard treadmill or bicycle ergometer protocol while monitoring the patient's ECG, BP and general condition. Flat or down-sloping ST segment depression of is greater than or equal to 1 mm is indicative of ischemia. Up-sloping ST depression is less specific and often occurs in normal individuals. Exercise testing is also a useful means of assessing the severity of coronary disease and identifying high-risk individuals. For example, the amount of exercise that can be tolerated and the extent and degree of any ST segment change provide a useful guide to the likely extent of coronary disease. Exercise testing may produce false positive results in the presence of digoxin therapy, left ventricular hypertrophy, bundle branch blocks or WPW syndrome. The predictive accuracy of exercise testing is lower in women than men. The test should be classed as inconclusive rather than negative, if the patient cannot achieve an adequate level of exercise because of locomotor or other non-cardiac problems. Other forms of stress testing. Myocardial perfusion scanning. This may be helpful in the evaluation of patients with inconclusive ET. We obtain nuclear scans of the myocardium at rest and during stress that could be either exercise testing or dobutamine stress after the administration of an IV radioactive isotope, such as 99 technetium tetraphosphate. Thallium and tetraphosphate are taken up by viable perfused myocardium. A perfusion defect present during stress but not at rest provides evidence of reversible myocardial ischemia. A persistent perfusion defect seen during both phases of the study is usually indicative of previous MI. Stress echocardiography. This is an alternative to myocardial perfusion scanning and can achieve similar predictive accuracy. It uses transthoracic echocardiography to identify ischemic segments of myocardium and areas of infarction. The echo characteristically shows reversible defects in contractility or wall motion during exercise or pharmacological stress. Coronary arteriography. This provides detailed anatomical information about the extent and nature of coronary artery disease, and is usually performed with a view to coronary artery bypass graft, CABG, surgery or percutaneous coronary intervention. In some patients, diagnostic coronary angiography may be indicated when non-invasive tests have failed to establish the cause of atypical chest pain. The procedure is performed under local anesthesia and requires specialized radiological equipment, cardiac monitoring and an experienced operating team. Management, general measures. The management of angina pectoris involves a careful assessment of the likely extent and severity, the identification and control of risk factors such as smoking, hypertension and hyperlipidemia, the use of medicines to control symptoms, the identification of high-risk patients for definitive treatment like PCI or CABG to improve life expectancy. Symptoms alone are a poor guide to the extent of coronary artery disease. Stress testing is therefore advisable in all patients who are potential candidates for revascularization. An algorithm for the investigation and treatment of patients with stable angina is shown here. Management should start with a careful explanation of the problem and a discussion of the potential lifestyle and medical interventions that may relieve symptoms and improve prognosis. Anxiety and misconceptions often contribute to disability. For example, some patients avoid all forms of exertion because they believe that each attack of angina is a mini heart attack that results in permanent damage. Effective management of these psychological factors can make a huge difference to the patient's quality of life. Antiplatelet therapy. Low-dose, 75 mg aspirin reduces the risk of adverse events such as MI and should be prescribed for all patients with coronary artery disease indefinitely. Clopidogrel, 75 mg daily, is an equally effective antiplatelet agent that can be prescribed if aspirin causes troublesome dyspepsia or other side effects. Anti-anginal drug treatment. 5 groups of drug are used to help relieve or prevent the symptoms of angina: nitrates, beta blockers, calcium antagonists, potassium channel activators and an IF channel antagonist. Nitrates. These drugs act directly on vascular smooth muscle to produce venous and arteriolar dilatation. The beneficial effects are due to a reduction in myocardial oxygen demand, lower preload and afterload, and an increase in myocardial oxygen supply. Coronary vasodilatation. Sublingual glyceryl trinitrate (GTN) administered from a metered dose aerosol, 400 microgram per spray, or as a tablet, 300 or 500 microgram, will relieve an attack of angina in 2 to 3 minutes. Side effects include headache, symptomatic hypotension and, rarely, syncope. Patients should be encouraged to use the drug prophylactically before taking exercise that is liable to provoke symptoms. Sublingual GTN has a short duration of action. However, a variety of alternative nitrate preparations can provide a more prolonged therapeutic effect. GTN can be given transcutaneously as a patch, 5 to 10 mg daily, or as a slow-release buccal tablet, 1 to 5 mg 6 hourly. GTN undergoes extensive first-pass metabolism in the liver and is ineffective when swallowed. Other nitrates such as isosorbide dinitrate 10 to 20 mg 8 hourly, and isosorbide mononitrate 20 to 60 mg once or twice a day, can be given by mouth. Headache is common but tends to diminish if the patient perseveres with the treatment. Continuous nitrate therapy can cause pharmacological tolerance. This can be avoided by a 6 to 8 hour nitrate-free period, best achieved at night when the patient is inactive. If nocturnal angina is a predominant symptom, long-acting nitrates can be given at the end of the day. Beta blockers. These lower myocardial oxygen demand by reducing heart rate, BP and myocardial contractility, but they may provoke bronchospasm in patients with asthma. In theory, non-selective beta blockers may aggravate coronary vasospasm by blocking the coronary artery beta-2 adrenoceptors, and so a once-daily cardioselective preparation is used, for example slow-release metoprolol 50 to 200 mg daily, bisoprolol 5 to 15 mg daily. Beta blockers should not be withdrawn abruptly because this may have a rebound effect and precipitate dangerous arrhythmias, worsening angina or MI, the beta blocker withdrawal syndrome. Calcium channel antagonists. These drugs inhibit the slow inward current caused by the entry of extracellular calcium through the cell membrane of excitable cells, particularly cardiac and arteriolar smooth muscle, and lower myocardial oxygen demand by reducing BP and myocardial contractility. Dihydropyridine calcium antagonists, such as nifedipine and nicodipine, often cause a reflex tachycardia. This may be counterproductive, and it is best to use them in combination with a beta blocker. In contrast, verapamil and diltiazem are particularly suitable for patients who are not receiving a beta blocker, those with airways obstruction, because they slow SA node firing, inhibit conduction through the AV node, and tend to cause a bradycardia. Calcium channel antagonists reduce myocardial contractility and can aggravate or precipitate heart failure. Other unwanted effects include peripheral edema, flushing, headache and dizziness. Potassium channel activators. These have arterial and venous dilating properties but do not exhibit the tolerance seen with nitrates. Nicorandil 10 to 30 mg 12 hourly orally is the only drug in this class currently available for clinical use. IF channel antagonist. Ivabradine is the first of this class of drug. It induces bradycardia by modulating ion channels in the sinus node. In contrast to beta blockers and rate-limiting calcium antagonists, it does not have other cardiovascular effects. It appears to be safe to use in patients with heart failure. Although each of these anti-anginal drugs is superior to placebo in relieving the symptoms of angina, there is little evidence that one group is more effective than another. It is conventional to start therapy with low-dose aspirin, a statin, sublingual GTN and a beta blocker, and then add a calcium channel antagonist or a long-acting nitrate later if needed. The goal is the control of angina with minimum side effects and the simplest possible drug regimen. There is little evidence that prescribing multiple anti-anginal drugs is of benefit, and revascularization should be considered if an appropriate combination of two or more drugs fails to achieve an acceptable symptomatic response. Invasive treatment. Percutaneous coronary intervention (PCI).
Percutaneous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. In this procedure, doctors insert a long, thin tube called a catheter in an artery, in the groin or wrist, and thread it to the affected artery using X-ray imaging. Doctors then inject a small amount of dye through the catheter to the artery to help them see any blockages or narrowing on X-ray images. A catheter with a balloon on the tip is then inserted through the first catheter and guided to the heart. When the catheter reaches the narrowed or blocked area of the artery in the heart, doctors inflate the balloon to reopen the artery and improve blood flow. The balloon is then deflated and removed. In most cases, doctors then insert another catheter with a mesh tube attached, called a stent. The stent is then placed in the narrowed area of the artery to prevent re-narrowing after the artery is widened. Doctors then remove the catheter.
Coronary surgery is usually the preferred option in patients with three-vessel or left main stem disease, although recent trials have demonstrated that PCI is also feasible in such patients. The main acute complications of PCI are occlusion of the target vessel or a side branch by thrombus or a loose flap of intima coronary artery dissection, and consequent myocardial damage. This occurs in about 2 to 5% of procedures and can often be corrected by deploying a stent. However, emergency CABG is sometimes required. Minor myocardial damage, as indicated by elevation of sensitive intracellular markers, troponins, occurs in up to 10% of cases. The main long-term complication of PCI is restenosis, which occurs in up to 1/3 of cases. This is due to a combination of elastic recoil and smooth muscle proliferation, neo-intimal hyperplasia, and tends to occur within 3 months. Stenting substantially reduces the risk of restenosis, probably because it allows the operator to achieve more complete dilatation in the first place. Drug-eluting stents can reduce this risk even further by allowing an antiproliferative drug such as sirolimus or paclitaxel to elute slowly from the coating and prevent neo-intimal hyperplasia and in-stent restenosis. There is an increased risk of late stent thrombosis with drug-eluting stents, although the absolute risk is small, less than 0.5%. Recurrent angina, affecting up to 15 to 20% of patients receiving an intracoronary stent at 6 months, may require further PCI or bypass grafting. The risk of complications and the likely success of the procedure are closely related to the morphology of the stenosis, the experience of the operator, and the presence of important comorbidity, for example diabetes, peripheral arterial disease. A good outcome is less likely if the target lesion is complex, long, eccentric or calcified, lies on a bend or within a tortuous vessel, involves a branch or contains acute thrombus. In combination with aspirin and heparin, adjunctive therapy with potent platelet inhibitors, such as clopidogrel or glycoprotein 2b3a receptor antagonists, improves the outcome of PCI, with lower short and long-term rates of death and MI. Coronary artery bypass grafting, CABG. The internal mammary arteries, radial arteries or reversed segments of the patient's own saphenous vein can be used to bypass coronary artery stenosis. This usually involves major surgery under cardiopulmonary bypass, but in some cases, grafts can be applied to the beating heart, off-pump surgery. The operative mortality is approximately 1.5%, but risks are higher in elderly patients, those with poor left ventricular function and those with significant comorbidity, such as renal failure. Approximately 90% of patients are free of angina 1 year after CABG surgery, but fewer than 60% of patients are asymptomatic after 5 or more years. Early post-operative angina is usually due to graft failure arising from technical problems during the operation, or poor runoff due to disease in the distal native coronary vessels. Late recurrence of angina may be due to progressive disease in the native coronary arteries or graft degeneration. Less than 50% of vein grafts are patent 10 years after surgery. However, arterial grafts have a much better long-term patency rate, with more than 80% of internal mammary artery grafts patent at 10 years. This has led many surgeons to consider total arterial revascularization during CABG surgery. Aspirin, 75 to 150 mg daily, and clopidogrel, 75 mg daily, have both been shown to improve graft patency, and one or other should be prescribed indefinitely if well tolerated. Intensive lipid-lowering therapy slows the progression of disease in the native coronary arteries and bypass grafts, and reduces clinical cardiovascular events. There is substantial excess cardiovascular morbidity and mortality in patients who continue to smoke after bypass grafting. Persistent smokers are twice as likely to die in the 10 years following surgery than those who give up at surgery. CABG improves survival in symptomatic patients with left main stem stenosis or 3-vessel coronary disease involving LAD, circumflex and right coronary arteries, or 2-vessel disease involving the proximal LAD coronary artery. Improvement in survival is most marked in those with impaired left ventricular function or positive stress testing prior to surgery and those who have undergone left internal mammary artery grafting. Neurological complications are common, with a 1 to 5% risk of perioperative stroke. Between 30% and 80% of patients develop short-term cognitive impairment that is often mild and typically resolves within 6 months. There are also reports of long-term cognitive decline that may be evident in more than 30% of patients at 5 years. Prognosis. Symptoms are a poor guide to prognosis. Nevertheless, the 5-year mortality of patients with severe angina, NYHA class 3 or 4, is nearly double that of patients with mild symptoms. Exercise testing and other forms of stress testing are much more powerful predictors of mortality. For example, in one study, the 4-year mortality of patients with stable angina and a negative exercise test was 1%, compared to more than 20% in those with a strongly positive test. In general, the prognosis of coronary artery disease is related to the number of diseased vessels and the degree of left ventricular dysfunction. A patient with single vessel disease and good left ventricular function has an excellent outlook, 5-year survival greater than 90%, whereas a patient with severe left ventricular dysfunction and extensive 3-vessel disease has a poor prognosis, 5-year survival less than 30% without revascularization. Spontaneous symptomatic improvement due to the development of collateral vessels is common. Angina with normal coronary arteries. Approximately 10% of patients who report stable angina on effort will have angiographically normal coronary arteries. Many of these patients are women and the mechanism of the symptoms is often difficult to establish. It is important to review the original diagnosis and explore other potential causes. Coronary artery spasm. Vasospasm in coronary arteries may coexist with atheroma, especially in unstable angina. In less than 1% of cases, vasospasm may occur without angiographically detectable atheroma. This form of angina is sometimes known as variant angina, and may be accompanied by spontaneous and transient ST elevation on the ECG. Prinzmetal's angina. Calcium channel antagonists, nitrates and other coronary vasodilators are the most useful therapeutic agents but may be ineffective. Syndrome X. The constellation of typical angina on effort, objective evidence of myocardial ischemia on stress testing, and angiographically normal coronary arteries is sometimes known as Syndrome X. With this we come to the end of this lecture. Hope you enjoyed it.